My name is Viktoriya Sapkalova, and I'm a second-year medical student at MCG, and I will be talking about a case of emphysematous cystitis. A 68-year-old female was brought in via EMS for altered mental status for a duration of 4 days. Upon arrival, EMS found that her blood sugar was 510, and there was a limited history available because of the patient's mental status. But according to her family, she had been feeling generally unwell with no specific complaints for the last couple of days, and they had waited to call EMS because they thought that she would improve on her own. Her past medical history was significant for hypertension, type 2 diabetes mellitus, peripheral artery disease, atherosclerosis, coronary artery disease, status post-stenting, vascular graft, mesenteric ischemia, gastroparesis, and fibromyalgia. So she had a lot of comorbidities. On physical exam in the ED, her heart rate was found to be 169, respiratory rate 46, blood pressure 86/45, oxygen saturation of 92%. Some pertinent physical exam findings were that, in general, she appeared somnolent, disoriented, and poor hygiene, but in no acute distress. Her GU exam was significant for dermatitis and stool in her diaper. And because of these findings, there was a concern for elder neglect, so a social work consult had to be obtained. Her MSK exam was significant for bilateral below-the-knee amputations, and this was due to the various comorbidities that she had presented with. On labs, her glucose was found to be 719 with a hemoglobin A1C of 15.6%. Her renal function was compromised. Her BUN was 78, creatinine 3.63. She also had leukocytosis with a white count of 19.4. In addition to this, she had pseudo-hyponatremia. So while her sodium was found to be 128 on labs, after you correct for the sodium because of the large amount of glucose that was present, her corrected sodium was 138, which makes her corrected anion gap 35, and her venous pH was found to be 7.19. On urinalysis, a large amount of glucose was found in her urine, as well as blood, white blood cells, red blood cells, bacteria, and a lot of yeast. And something important here is that there were no ketones in her urinalysis, so because of the lack of ketones, she was determined to have a hyperosmolar hyperglycemic state with a high anion gap metabolic acidosis as opposed to diabetic ketoacidosis. This is her CT abdomen pelvis. And this is her CT in the coronal view. And this is the sagittal view. So some pertinent findings from her imaging was significant circumferential thickening of the bladder wall and a large volume of gas in the bladder wall, which is consistent with the presentation of emphysematous cystitis. She also had a large volume of free air within the extraperitoneal space of Retzius and regions of non-enhancement of the bladder wall, and this was concerning for extraperitoneal rupture secondary to bladder wall necrosis. Her CT abdomen pelvis also demonstrated some mild bilateral hydroureteronephrosis, as well as multiple locules of free air within her abdomen and pelvis. So 2 blood cultures and a urine culture were drawn when she first came in, and both these blood cultures and the urine culture were found to be growing Candida glabrata, and one of the 2 blood cultures also grew Staphylococcus epidermidis, but this was deemed to be a contaminant. And on repeat cultures that were drawn 2 days later, both of these blood cultures were positive for Candida glabrata, and the urine culture was also positive for Candida glabrata. Repeat blood cultures drawn 5 days after admission showed no growth, and urine cultures remained positive for 9 days after admission. So the patient was placed on a broad treatment regimen of mycofungin, cefepime, vancomycin, piperacillin-tazobactam, and metronidazole. Metronidazole was later recommended to be discontinued by infectious disease due to the lack of presence of any anaerobic organism on cultures. And eventually, infectious disease also recommended for cefepime to be de-escalated to ceftriaxone and then discontinued altogether because there was no evidence of any gram-negative organism on culture as well. And as per IDSA guidelines for Candida glabrata candidemia, her treatment was switched from mycofungin, which is an echinocandin, to high-dose fluconazole. So she was admitted to the MICU for treatment of septic shock, and a Foley catheter was placed to decompress her bladder. And because the bladder rupture was extraperitoneal, there was no surgical intervention that was deemed necessary at the time. And in addition to this, because of her various comorbidities, as well as a very high hemoglobin A1C and blood sugar, when she came in, she would not be a good surgical candidate as well. So the patient was intubated on her 3rd day because she was desatting to the 80s while on 5 liters on nasal cannula. And a TTE that was performed on the 3rd day of admission was significant for reduced ejection fraction, grade 1 diastolic dysfunction, and global hypokinesis of the left ventricle. And 5 days after intubation, the patient was able to be extubated to high-flow nasal cannula, and 8 days into her hospital course, she was able to be transferred to the hospital of service, but unfortunately, the very next day, because of acute hypoxic respiratory failure, she had to be transferred back to the MICU, and she had to be re-intubated because her PaO2 was 44 when she was on 100% of high-flow nasal cannula. There was also a high suspicion of a pulmonary embolism because of her elevated D-dimer. So she was started on heparin, but a CTA of her chest ruled it out. And her troponins were being trended during her admission, and they were found to be uptrending on the 14th day of admission, so she was diagnosed with an NSTEMI. And by the 17th day, she was able to be extubated and placed on trach collar with PRVC. However, during her hospital course, she remained intermittently tachycardic, tachypnic, and febrile. So because her clinical picture did not look very good, the goals of care discussion was had with her family, and her husband and granddaughter decided to allow for a natural death if the patient were to pass away. So they didn't want her to be full code. And her vitals on the morning of her 22nd day of admission were a heart rate of 114, respiratory rate of 41, a very low blood pressure, 52/43, and a MAP of 47. Her morning labs were significant for a lactic acid of 13.10, a pH of 7.16, and an arterial PO2 of 47. And she did end up passing away that same day, and her cause of death was determined to be multi-organ failure, cardiac arrest, and respiratory failure. So some key points about emphysematous cystitis is that emphysematous cystitis is a rare condition and its symptoms vary widely. So you could have a patient who presents with symptoms of a mild UTI or somebody whose emphysematous cystitis is just found incidentally on imaging, but you can also have somebody who presents in a very critical condition and septic shock like this patient. The hallmark of emphysematous cystitis is air in the bladder wall or bladder lumen, and it can be caused by gas-producing microbes, instrumentation during GU procedures, or fistulas. So the exact mechanism is unknown, but with patients with emphysematous cystitis, over 50% of them have diabetes. So it is thought that the high glucose concentration acts as a substrate for these microbes and allows them to undergo fermentation and produce carbon dioxide. And the mechanism behind fistulas causing emphysematous cystitis is usually due to diverticular disease. So you have increased intraluminal pressure within the sigmoid colon, and you have outpouchings of the submucosa and the mucosa, and these outpouchings eventually create a colovesicular fistula, and that way there is air introduced into the bladder from the colon. And E. coli and Klebsiella pneumoniae make up the majority of organisms found in urine cultures. So E. coli accounts for about 60% of positive urine cultures in emphysematous cystitis, and Klebsiella pneumoniae accounts for about 10 to 20%. Other organisms are reported, but they are reported rarely. And while Candida albicans and Candida tropicalis have been reported to cause emphysematous cystitis, to our knowledge, our patient is the first case of emphysematous cystitis caused by Candida glabrata. Candida glabrata has been noted to cause emphysematous pyelonephritis, but has not been implicated in emphysematous cystitis as far as we know. The typical patient who presents with emphysematous cystitis is an elderly woman with diabetes mellitus, and diabetes mellitus is the biggest risk factor for emphysematous cystitis. Diagnosis is made by radiographic findings as opposed to symptoms, because the symptoms are very nonspecific and vary widely among patients, but a prompt diagnosis is associated with improved outcomes. And emphysematous cystitis can usually be managed in about 90% of cases by medical management alone, such as glycemic control, antimicrobial coverage, and urinary drainage. About 10% of cases need surgical intervention, such as debridement and partial or total cystectomy. And it is important to consider the possibility of complicated UTIs in patients that present with comorbidities. So while emphysematous cystitis is a very rare diagnosis, and obviously not every patient who has diabetes mellitus and presents with abdominal pain is going to have emphysematous cystitis, it is still very helpful to keep this diagnosis in mind, even if it is on the very bottom of your differentials. Because again, prompt diagnosis is associated with improved outcomes for the patients.